The ending of last session was a very nice segue to this third session. It's all about people. So the delivery of surgical services, the management behind it, it all comes down to individuals. Guiding principles like universal health coverage, health system change or strengthening or access and quality, it's about people. And if we want to achieve the mission, the vision of this commission, we need adequately trained and educated individuals, adequately distributed, being in the right time at the right place. So at the very beginning of this commission work, we dedicated a special working group to the workforce, the education and training. And it's with great honor and pleasure that we soon will listen to Professor Emmanuel Ameh, my friend, pediatric surgery colleague, who will summarize the findings of this working group. Professor Ameh is a consultant surgeon and professor in pediatric surgery in Nigeria, and in Abuja first, and then in Zaria, and then moved to Abuja. His career bear witness of a passion for surgical training and a commitment to the expansion of workforce for surgical care, in particular for children. And you have worked with colleagues from all around the world to strengthen the surgical workforce, and we're very grateful for that. You have written several textbooks specifically dedicated to teaching surgery as it applies to sub-Saharan context. And after your presentation, Emmanuel, we will have a panel here of 4. I would like you all to take your seats, please, the panelists. We have Martin Smith. Thank you, Martin. Martin is also a surgeon, an HBB surgeon and a clinical lead, and also the academic head of surgery and assistant head of the School of Clinical Medicine at the University of Witwatersrand in Johannesburg. He was the president of the Pan-African Association of Surgeons from 2012 to 14, and had been a brave fighter for the equal access to surgical care in South Africa for a very long time. Thank you. Pankaj Jani, Professor Pankaj Jani, a consultant surgeon, also clinical lead, and Secretary General of the College of Surgeons of East and Central and Southern Africa, COSAXA, and the Vice Chair of the G4 Alliance. So Professor Jani is incredibly well respected, and no one knows the realities and the possibilities of surgical training like you do. Thank you, Professor. Then Wayne Morris, anesthesiologist from Christchurch, New Zealand, thank you, who has worked for 2 years in Fiji. And he's the current chair of the Education Committee of the World Federation of Societies of Anesthesiologists. So he has thorough experience of designing and teaching on courses in low-resource settings. And finally, Meena Cherian, thank you. You have the advantage of starting off as a general doctor and in the rural area performing surgical obstetrics. And then you for 5 years or so, and then you specialized in anesthesiology, became a professor, and has led the WHO surgical program for many years, and the WHO Global Initiative for Emergency Essential Care. Thank you all. So after the presentation of Professor Ameh, we will have brief comments from the panel, and then we will open up questions from the floor. Thank you very much.
Thank you, Lars. Good morning. I'll start off by just telling you a short story. I met a colleague, a very senior colleague, he's a professor of surgery, a few days ago. He had spent about 35 years working in a teaching hospital, and a few months ago, he decided to take a sabbatical back to his home state to work in a secondary level hospital. And he said to me that when he got there, he found more than 10 patients, both adults and children with intestinal obstruction, who had been on admission for more than 2 weeks, being given salt and water solution because there was no surgeon to do the surgeries. And when he appeared as a surgeon to do the surgeries, there was no anesthetist to provide a safe anesthesia. And for several days, he had to run around trying to get the patients sorted out. And the distance between that hospital and his teaching hospital where he worked for 30 years was just about 100 kilometers. And that's the challenge we have across most of low and middle income countries when it comes to workforce. So I'm going to be presenting the summary of the work of the Workforce Training and Education Working Group of the Commission. For the purpose of this work, we define the surgical workforce as the interdependent network of all professionals, all personnel, both clinical and non-clinical, who work together to provide surgical care. So it extends beyond the actual surgeons. But for the purpose of this report, we are going to focus on surgeons, anesthetists, and obstetricians, which we call SAOs from now. What we all probably agree on now is that there is a severe shortage of SAOs across the world, mostly, especially in poor countries. And there's a problem, there's an inequity in their distribution. But just how much this shortage is has been difficult to quantify. And how bad the inequity in distribution is has also been difficult to quantify until now. So what the Commission did was first to look at what exactly exists at the moment. And working with the WHO provider database, with Meena and her group at the WHO, what we found was that at the moment across the world, we have about 1 million specialist surgeons, 550,000 specialist anesthetists, and about 480,000 specialist obstetricians. And that is just about numbers. But how are they distributed? This is across the entire world. Now, about 1/6 of the anesthesia, the specialist anesthesia workforce, 1/5 of the surgeons, and 1/4 of the obstetricians serve half of the world. And that is really small for that part of the world. And still going further, we know that in Africa and South Asia, about 1/3 of the world population live there. But they are served by just 12% of this entire surgical workforce, the SAOs, just 12%. And that creates such a severe limitation in terms of the numbers in that part of the world. And we did say from the beginning that what we want to achieve is to provide a universal access to safe and timely surgical and anesthesia care across the world. But with these numbers, we know this is simply not possible, especially in low and middle income countries. So the point is, how much do we really need? How much is enough to provide universal access to safe, affordable, and timely surgical care? So the Commission went further, and based on data available to us, we, again from the first session, we all agree that we need to have strong healthcare systems. Without strong systems, it's difficult to provide safe and affordable surgical care. And one of the measures or indicators of good quality and strong healthcare system is the maternal mortality ratio. So we used this, and what we found was that taking countries, about 143 countries across the world, countries that have achieved about 40 SAOs per 100,000 population, the maternal mortality ratio is small in those, is good in those countries. And with increase beyond that 40 SAOs, even though there is still some gain, some improvement in the maternal mortality ratio, that improvement really is not terribly significant. We also found that below 20 SAOs, there is a significant problem with maternal mortality ratio. For every 10-unit rise or increase in SAOs, there is about 13% gain in improvement in maternal mortality ratio. So based on that, the Commission recommends that between 20 and 40 SAOs, if any health system that can achieve that, to have this kind of good maternal mortality ratio, it then means that that is a strong enough healthcare system to support surgical, essential, and safe and affordable surgical care. So from now onwards, we are going to base most of our discussion on those numbers. So based on those numbers, we find that 44% of the world's population live in countries where they have less than 20 SAOs per 100,000 population. And those countries are the countries that have very poor maternal mortality ratios. 28% of countries around the world, and these are mainly the high-income countries, they have more than 40 SAOs per 100,000 population. So using the 40 as the upper threshold, at the moment, we then have 1 million shortage of SAOs in 136 low and middle income countries, which means if they can achieve this number, they should be able to reach 40 SAOs per 100,000 population. And in the next 15 years, we need a minimum of additional 2.28 million SAOs to reach that 40 SAOs per 1,000 population in these 136 countries. But we know that for most countries, 40 SAOs per 1,000 population is not practicable, either because they don't have the resources, the financial resources, or even the human resources to train to achieve that number of SAOs. So using the lower threshold, that's 20 SAOs per 1,000 population, we find that most countries in sub-Saharan Africa and Southeast Asia need to significantly increase their numbers in order to reach that level. Right, so for many of these countries, since they really don't even have the resources, the human resources to train specialist surgeons to get to that point, at the moment, from the researches of the Commission, about 30 countries at the moment practice task shifting, surgical task shifting for surgical procedures. And 108 countries practice this in anesthesia. But we do know that task shifting has been a very controversial issue. So for the Commission, based on the aspiration of maximizing human resources and providing high-quality care, the Commission chooses to use task sharing, which really is a rational redistribution of procedures and services from highly trained personnel to personnel with a lower and shorter duration of training and less qualification. But the key point is that the aim is to maximize available resources, is to share, there should be a shared responsibility. So it's not about moving care to a lower cadre of staff without following up and mentoring what is happening there. And the aim is also to have a high quality outcome. So mentoring is a very significant part of this task sharing. Now, because it takes so much time to train a specialist, surgeon, anesthetist, or an obstetrician, we found that if low and middle income countries are going to be training only SAOs, or if they are going to train some SAOs and also have task sharers, if they have task sharers, there will be a cost and time saving of about 40%. But we do acknowledge that one cap does not fit everyone, and every country really should decide based on their resources and their needs. They should decide whether tax sharing is appropriate for them or not. If it is appropriate, they should decide what level of tax sharing they need to embark on. But very importantly is the fact that task sharers are not meant to replace specialists, SAOs, and they should not distract resources from the training of specialist SAOs. The scope of practice needs to be clearly defined because that has always been one of the challenges. This will avoid task creep. This will avoid having the associate clinicians having to take up so much of some of the things that they're actually not trained to do. And they should be subjected to very high standards of accreditation. Right, but this is about numbers. We know we do need all this number, but how do we get there? The Commission recommends that countries can decide on a number of options in order to train their specialist SAOs. This can be done using the private sector, because we know that in the private sector, the highly trained personnel exist, and they also have the resources to carry on some of these trainings. So many NGOs do a lot of work in low and middle income countries, and the Commission recommends that training should be an important and integral component of what the NGOs are doing. So it's not about offering services alone. They should also include training and scaling up of workforce in their programs. Partnerships, regional partnerships already exist, but these need to be strengthened. Where they don't exist, they need to be developed in order to share resources, available resources to increase training. Partnership with high-income countries also already exist, but they need to be strengthened, and they need to be harnessed in a focused manner without having too much duplication in the same country, have too many different groups doing the same thing without achieving what should be achieved. The trainers obviously need to be trained, because one of the challenges in low and middle income countries is that there are simply not enough trainers. The available trainers, many of them are also sequestrated in very small areas and isolated, and they require a lot of training. But this, again, is about the numbers. But what about the distribution? In most low and middle income countries, outside the major cities, surgical care simply doesn't exist. And how do we get about that? So it's important for the trainees to have some rural exposure during their training. Presently, some of the training colleges, particularly in sub-Saharan Africa, COSEXA is already doing that as part of their training program. The West African College of Surgeons is also already doing that as part of their programs, and these need to be strengthened. Training needs to be done in a local context and should be tailored towards local needs. In order to retain SAOs in rural areas, because again, that's one of the major challenges that exist in those areas, there should be some rural incentives, and countries should decide how they do that. There should be some rural incentives to retain these specialists in those areas. Now, we do know that numbers don't mean quality. You can have so many, but what about the quality? So, and we need to keep in focus the fact that as we expand the numbers that we are training, we shouldn't lose sight of the quality of the training. And in order to do that, trainings need to be competency-based. The curriculum needs to meet local needs. It's not about extrapolating what curriculum exists in one part of the world and taking it to another part of the world. The curriculum should be designed in such a way as to meet specific the needs of the communities where those that are trained are going to actually function. Because numbers are involved here to train large numbers of people, sometimes simulation may be required to help in improving the quality of training. Accreditation of programs for all cadres of personnel that will be involved in surgical care need to be properly accredited to ensure a high standard and a uniform standard of training. There needs to be licensing and relicensing. And for the trainers, a continuing professional development is important for them to maintain their skills and knowledge. So that's the summary of the work of the committee, of the commission, the Workforce Training and Education Working Group. And I've presented this on behalf of all the members of that working group. Thank you.
Emmanuel. Martin, please.
Thank you, Emmanuel. I really feel that this component of the Commission was really excellently addressed. And so I think that in my comments, it's really to highlight some of the issues that have been raised. But to start off and say that to double the workforce by 2030 is a huge undertaking, and one that cannot be done in isolation and certainly requires partnerships and integration. And so I guess it's about the relationship between health system strengthening and education, and really to recognize that neither of these can happen in isolation. And so as the discussion in the last session went, where we moved from health system strengthening into significant comments around strengthening the human resources, it's quite clear that, that education and training cannot happen in isolation, and that the partnerships need to be strengthened, both with local governments, both with regions, but also with international colleges and international NGOs that have been working so tirelessly in Sub-Saharan Africa, where my experience of it really is based. So it really is about the integration of the training platform and the integration of the service platform. And really it's about the transformation of both of them. We heard about the relationship between service provision and health system strengthening, and I think that the combination of the two really defines for me the context of transformation that is required. I think that one of the big issues for me is really the concept of competency-based training. Because what we haven't done very well, I think, in Sub-Saharan Africa is really dissected out the competencies that are necessary to provide safe, effective, and timely surgery. And I think if we had done that better, the ability to integrate different cadres of health workers into the surgical workforce would probably not be as controversial as it is right now. One of the important attributes that I think surgery brings to health system strengthening is the concept of teamwork. And so when one considers how task shifting or task sharing may be integrated into the team, I think if we combine that with competency-based training, the understanding of the fact that we're never going to achieve a doubling of the workforce by 2030, and that if we look at it from a competency-based approach, we will be able to then identify the role in the team of a whole range of health professionals in delivering equitable and universal access. So I think that the issue around task sharing and task shifting is one that we need to continue to debate. I think it's one where colleges and professional associations in Sub-Saharan Africa really need to recognize their responsibility broader than to the individual patient and to the individual disease, but really look at the community. And it's an important area where we will integrate into the primary healthcare model and the global health approach. So I think that's one of the areas that we need to focus on in terms of our education and training is about attitudinal change. We need agencies like the Lancet Commission to assist us in driving the political and policy change. But I think that we as professionals also need to focus very clearly on our own profession and ensure that attitudinal change is brought about. We need to shift our approach away from just focusing, as surgeons must do, on the individual patient, but looking broader than that and making sure that this is an integral part of our education of the next generation of surgeons. Because we can shift governments, but if we don't shift the profession itself, I think that this critical success success factor for global surgery will not be able to be realized. And so it's very important that the work done by the Commission at policy level is supported by the work inside the profession. And I think this is an important responsibility for colleges and training of the health professional to realize that end.
Thank you very much. It's an honor for me to be invited by Lancet, and I'm really grateful that I see the hall that's full, filled with champions who will definitely assist us reach our goal. We've been talking about 5 billion people not having access to safe, timely, affordable surgery, 150 million operations to be required every year, 33 million people who will have out-of-pocket expenses and become poor. But I'm going to give you some good news. There is light at the end of the tunnel. My task today is the workforce. And we realized this in 1999. We, meaning my teachers who were senior surgeons in the EXA countries, which is East, Central, and Southern Africa, and we formed a College of Surgeons there, which is COSEXA, College of Surgeons of East, Central, and Southern Africa. We have 10 countries at the present moment as member states, and we conduct training in 5 other satellite countries. The college was inaugurated in 1999, and we had our first examinations in 2003 with 4 candidates taking the examinations. And I'm glad to report that this year, there'll be about 120 taking the examinations. So there is light at the end of the tunnel. We're dealing with the staff here, the workforce, if the space which is required is there, and the space is there. If we can sort out the staff and the space is there, we've covered 50% of the burden. What remains is the stuff and the systems to be put into place. We in COSEXA look after a population of about 320 million. The reported model here of maternal mortality versus numbers is a model. I want you to get this very clear. It doesn't include the systems. Some of the maternal mortalities may be because the systems are not in place or the stuff is not there. As I alluded to earlier, the space is there, but getting to the space may be a problem. So staff and maternal mortality cannot be related directly. It's a model. And we say we need 20 SAOs, surgeons, anesthetists, obstetricians, per 100,000 people. In COSEXA, we feel this number is half that. We feel there is 10 per 100,000. That is the required need in the immediate period. So for 320 million people, you need about 32,000 surgeons. You still think it's feasible? I'm optimistic. If you take the numbers now, the numbers in that region, we have a workforce of about 1,600 to 2,000 surgeons. It's very difficult to get accurate numbers because various countries include various cadres as surgeons and others do not. But we have about 2,000, so we are short with 30,000. If you have 30,000 surgeons required, according to the SAO model, and you take the COSEXA model, which says 15,000 are required, then we examined over the last 5 years, the numbers have increased from 30 to 60 to 120. And with our partners, I must mention the Royal College of Surgeons of Ireland at the present moment, who've been strong supporters of COSEXA, we intend to double these numbers until we reach the flat part of the curve. And with the universities, which are also training surgeons, in the next 15 years, our target, and with your help, is going to be 5,000 surgeons. And this is feasible. This is what I'm trying to tell you. This is good news. You don't need antidepressants or anything. This is light at the end of the tunnel. Add the task sharers to this. We've already got programs in Zimbabwe, the ZEST program, which are doctors being trained to perform surgical procedures. Task sharing is what we are concentrating on, not task shifting. Task shifting is difficult in surgery because there is judgment, decision-making, there is ethics, professionalism, that all comes in treating a patient. But the technical skills part of it can be shared. So we're looking at it that way, and for every surgeon that we train, if we train 3 task sharers, then our workforce in the EXA region is met. Finally, you know all that the most important point here is working with champions. And as I started by saying, all of you here make me feel so happy that we have 300 champions in this room and we'll meet the goal. Thank you.
Good morning, everybody. I wish to thank the Lancet Commissioners for all their hard work. I am very honoured to be part of this panel. The WFSA is a federation of over 120 member societies representing hundreds of thousands of anaesthesiologists from all around the world. We have 4 main program areas: advocacy, education and training, safety and quality, and also innovation and research. There's a lot to talk about, but I just want to concentrate on a few themes related to workforce and training. And I'll be putting the WFSA point of view, but I think the themes and the issues are universal. The first theme is that we need to increase the number of surgical and anaesthetic providers quickly, as we have heard. Low provider numbers lead to poor morale, poor staff retention, and an increase in the surgical gap. This is a vicious cycle that we need to break. We have heard that in many countries, it will be necessary to use task shifting to increase the number of providers. The key word here is sharing, where a specialist provider is available to give assistance either locally or remotely, depending on resources. Training of non-specialist providers should not divert resources away from training of specialist providers. And these conditions should apply equally to surgery and obstetrics as well as anaesthesia. The Lancet Commission, as Emmanuel said, focuses on surgical, obstetric and anaesthetic providers, but an increase in these providers must be accompanied by the development of other members of the surgical team. For example, theatre nursing staff and ward nursing staff. And I think we've all seen examples of where one member of the specialist team has been trained to a high level, but he or she cannot do his or her work because there are parts of the team that are missing. The second theme is that clinical training needs to be appropriate. I know that I'm preaching to the converted here, but training programs need to take into account local resource constraints, disease patterns, and distributions of providers. If we can get these things right, then I think we increase the chance of specialists staying in their home country. The Bangkok Anaesthetic Regional Training Centre has trained 68 anaesthesiologists from Mongolia and Southeast Asia during the last 16 years. This is not a huge number, but 66 of the 68 have returned to their home countries and are currently working as anaesthesiologists. The location of training programs may help to address maldistribution in the workforce. We've already heard about COSEXA and how this promotes training in rural hospitals rather than large urban hospitals. We are expecting that an equivalent College of Anaesthesiologists will be launched in the same region of Africa early next year. The third theme is that we need to be training leaders and teachers, not just excellent clinicians. The Lancet Commission report uses the term change agents. People who will advance surgical and anaesthetic care and improve education and training. The other word that I personally like is champions, and I think we've already heard this a couple of times this morning. The aim of the WFSA training programs is to develop leaders and teachers as well as clinical experts. In addition, short courses such as primary trauma care, essential pain management, safe obstetrics and safe paediatrics all have a teacher training component and all emphasise early handover to local instructors and local ownership. With all of these educational programs, there can be many benefits for the host institution, including a strengthening of local faculty and improved regional cooperation. Finally, national and regional societies and colleges play a vital role in advancing anaesthetic and surgical care in their own countries and regions. Organisations like the WFSA can help to strengthen these societies and promote collaboration between different societies and NGOs. As a small example, we are currently working with Operation Smile and the Indian Society of Anaesthesiologists to develop an anaesthetic training program for cleft repair surgery in Assam, India. There are also many other examples of partnerships between high-income countries and low-income countries. In successful partnerships, both sides will benefit. To finish, I was sent this quote last night. Henry Ford said, "Coming together is a beginning, staying together is progress, and working together is success." Thank you.
It's springtime for surgery. Why? Because it's actually spring, and the seed that was sown many years ago, I've struggled with that, and it's so wonderful here that you see everything coming together. So this year, and since last year, with Lancet Commission, the World Bank, the Disease Control Priority book, which will be which is launched, volume 3, edition 3, one full volume on surgery, the Lancet Commission with a full report on global surgery. What more do we want? But yet, with these numbers that you saw, and I'm not going to give any numbers, because I think we have been overwhelmed with all these numbers. It is really now that the evidence has been given to you, how do we go about it? What do we do? There's lots to be done, and I think looks like now we're all together on this, and we are committed people. Because with all the indicators that you saw and everything that is coming around in the global indicators at the World Health Organization, the resolution which is coming, before that now if you talk about the workforce, you may remember there was a World Health report in 2006 which talked about scaling up of the health workforce in general. And that was some time ago. Then we had a resolution on that, just the work health force. Now, imagine we have it's all coming back. It's coming now to a resolution on surgery. And you'll be very pleased to know that, everybody aims in every paragraph for their area of work, from medicines to access to medicines to surgery to maternal mortality. And there is 2 or 3 paragraphs on health workforce, surgical health workforce. So that is a huge leap for all of us to be mentioned there as surgical health workforce. The fact that the global surgical workforce database has been established, which we are hoping that this will be like an observatory, and this will be a live thing where people can then look at it and see where is the gap. I would like to emphasize, everybody has emphasized already on task sharing and the numbers and what they are going to be doing for surgery and anesthesia. One of the things that I have noticed very much, because we have got this huge global database on surgical services, which includes obstetrics, anesthesia, and trauma. It's a huge database for more than 55 countries, more than 1,300 health facilities. And you may have seen some of the papers Especially, I will highlight the cesarean section paper on 22 low and middle income countries. If you look at it, one of the highlights is that people could not do cesarean sections because of lack of skills. And really, if you look at those figures, the tables, we were talking at the provincial and district hospital level. We did not go below that. So isn't that sad, that lack of skills? And therefore, you have a lot with partnerships coming. These partnerships, we would like to see it as sustainable partnerships, not just going on a camp and doing the service or training one time in one hospital, few people, and then the project is over. We would like to see, we have established a global initiative, WHO Global Initiative for Emergency and Surgical Care. It's a very huge initiative with more than 1,800 members, and all of you should, if you are not, you should be part of that, with 130 countries. And I think this is where the Lancet Commission and the World Bank, the group, all of us can join there and create these sustainable partnerships. Why do I say sustainable? Because I see a huge gap in anesthesia. And it's not because I used to be a professor of anesthesia. The reason is this. In one country, I'm not going to be naming countries, but I will give you examples. The government put in every health, this is community level, you can say community health center, obstetricians, because the maternal mortality was very, very high. So the government said, we have put obstetricians, specialists, because that country you have to have specialists. But what has happened? That they couldn't do cesarean section. The reason was there was no anesthesiologist posted there, in par with the obstetricians. And in this country, we don't have nurse anesthetists or others. It has to be anesthesiologists. So here it is with good intentions by the government. I don't believe that anybody does things with bad intentions. Always the intentions are good. The policy is good. It's just the implementation, there is a lack. I believe in that, and I will continue to believe in that. So here was a gap. There was another time when there are specialists we know that, it's in the urban setting. So now the programs were built around only a quick fix of only the mid-level health providers, which we are not against. We would like that, clinical officers, assistant medical officers, which are not doctors. But I think we need to have a balance. I know of countries where I frequent many times, there is not one single anesthesiologist, physician anesthesiologist, local. And are we expecting surgery to go, quality of surgery higher? Or we are happy with a quality of surgery or even the procedures just remaining as day-to-day, whatever you can. So there is an imbalance in that. And therefore, I would suggest that when we go back, now this resolution will be there in May, but this is not all. 194 countries, we are hoping, will adopt it. But WHO will have to, the Secretariat, that's the WHO, with the ministries of health, this whole thing is with the member states. We will have to then report back in 2017. What are we going to report? This is where we require everybody on board with us. And with this is my hope, my dream, and with this, I close. Thank you.
Thank you very much. Lovely presentations. Now we open up from questions from the floor, and when you do ask a question, introduce yourself, and if you have a specific person that you would like to direct your question to, then please. So, in the far back. Yes. Hang on, wait for the microphone so that the online viewers will hear you. Thank you.
Martin Kaspari, have some experience in NHS manager and also public and private in New Zealand, and soon to possibly be in a middle-income area. My question is this. We, in NHS and also in most Western nations, are short of surgeons, anaesthetists, certainly at a middle grade level, aren't we in danger of, while I applaud a lot of the things that are happening to train more surgeons, aren't we in danger of training more to meet demand in the UK, in New Zealand, in America, and drag what strategies to maintain those that are trained in the places where there's the greatest need?
I think it's about balancing the push and pull factors. So the pull factors are clear, you've described them. It's the push factors that I think we haven't addressed. So the push factors, in my opinion, is surgeons are comfortable working where they, or surgeons will work where they're comfortable, where they don't feel like they've been pushed outside of their margins of competency. So we've got to make sure that they have that competency. So the training has got to be appropriate for resource-poor environments. But there is a responsibility to making sure that the platform functions. And so if we don't have surgeons that are working in environments where they feel they're making a contribution, we increase the push factor multiple times. We also have to look at the people we're selecting to become surgeons. Are we selecting them from the right group? Are we selecting them from the right area? Do we need to be selecting people from rural areas to go back to work in rural areas? And so I think that it is much about what we do in middle and low-income countries that affect the push factor. And that's where I think most of our work needs to be done. We need the support, and I think the Lancet Commission will add to that support, of governments to understand that to improve the platform in which surgeons are working, the teams that surgeons are working, is going to be something that will mitigate against the push factor.
I want to conclude this one. This one.
Yep.
This one now. This. Yes. Yeah. Thank you. Well, I just want to congratulate the working group on workforce. I just want to push a notion that is implied but not specifically dealt with. And that's the notion of strategic formation of an integrated surgical workforce. What do I mean by that? I mean by that you have the Association of Surgeons, the universities that train surgeons, and the surgeons themselves, both also the same with anesthesiologists and obstetricians, working together to develop the workforce. In this way, you have mentoring, monitoring, quality assured, and you have a strategy that could be implemented for a region. And with the use of modern technology, you can actually monitor the middle-level workers in the districts adequately. So I think that the notion, going one further than what you have, integrating, suggesting a strategic integration of the surgical workforce.
Emmanuel? Emmanuel? Please stand up, Emmanuel.
Sorry, I have to speak again. I'm used to speaking a lot because I'm a global health diplomat, a surgeon before that. And so I discuss most of these things all the time, and I've done this over the resolution. I'm looking out for government. If we're going to double the workforce, and we're saying that the responsibility should go to governments, so I'm going to speak as... Okay, I was saying that I work as a global health diplomat, and I look out for my government at the UN, and I'm going to speak as a government representative. If we're going to double the number of surgical workforce. As a government, we have to think about investing in that. How are you going to convince us as a government to think that it's meaningful for us to have to invest so much money to double the numbers? That's the question. And I think that's the big thing that going forward, all of you champions have to think about. We have the report, we've generated evidence, but how do we buy in as governments? How are you going to convince us as governments to buy into that report, to implement that report? So here you have to be very strategic. And governments always listen to good things, like what will be the benefit for the government? The illustration of how surgical intervention eventually results into economic development for the country is very key. You have to clearly elaborate that point. How making sure that a fractured femur can improve somebody's economic output and eventually improve his family economic performance, the community, and then the country. That link has to be clarified and very clear for government to buy in. Secondly, if we're going to invest into training, first of all, like you said, we have to be sure that we're training for people that are going to stick around. There's no need for me to train for the Americans. I don't have the money to do that, and not even the will to do that. So the training has to be customized to the local situation, and of course, the pull factor. How do I maintain the staff within the country? But overall, I have to be convinced as a government that it's a good investment. How is it going to be a good investment into my people? As a government, we're struggling with job creation. We have tons and tons of young people graduating from universities and especially high schools, and governments are struggling to find employment for them. And yet there's a big gap in the health workforce, which we've already planned for many years. We've always planned for so many people. We even budget for it, but we don't have the people to fill up those places. So as you go forward again, if you're going to convince governments to really make that investment, they have to be convinced that they are actually creating jobs for their people. They have to look at it from that perspective. You are creating jobs for your young people who are going to be taxpayers, who are going to grow your economy. You have to put all the economic pieces into it. That is what will convince governments. But of course, there will be other things. But I wanted to highlight those as very important for governments today. They want to use their money very, very well, and they want to score very high with very little money. It has to be convincing. The evidence is there, but until and unless you convince governments, it will remain a report that we'll put on the shelf, it will be a resolution that we put on the shelf, and nothing happens. Thanks.
Thank you. Many hands in the air. Well, a couple of more questions. The lady behind here. Yeah. Yes.
Kim Sanders Fisher, after a 10-country tour of sub-Saharan Africa looking into anesthesia care needs, and on coming back and reading the Nigel Crisp book, Turning the World Upside Down, which is a fantastic book, and talks in a very hopeful terms, I can't help feeling that if Africa and other lower and middle-income countries are training people that are being scavenged by countries overseas, rich countries overseas, that if their level of training is that good, why aren't we outsourcing some of our training to those countries and working in collaboration, training some of our people alongside some of their people in their countries where it's cheaper to train people, and then having those people build a lifetime of collaboration so that when they come back to their countries of origin, they maintain a contact with somebody that they trained with somewhere else in the world. Is that something that you would consider or that has come up in discussions at all?
Comments from Emmanuel, perhaps?
Yes, I think that's still about the partnership part between the high-income countries and the low-income countries. But I think a critical aspect to always have in mind is the fact that this has gone on for some time. Either people train there with people coming from high-income countries to train them, or they come to high-income countries and train and go back. And we've had so many situations where after a few years, they actually leave. Not because of money, but because the health systems are not strong enough, they can't do what they are trained to do. And that is why I think strengthening the system will be a very key part of keeping them there, because if you are trained, you know what you can do, and you simply don't have the support, the system does not allow you to do what you are trained to do. It's very frustrating. And that is one of the very important push factors that get them out of there.
Thank you. So we have many, many hands in the air. We have 5 more minutes. So brief questions, please. First here, and then over to you.
Thank you. I just want to respond to the call that we are all part of making sure that the WHO resolution is impactful and takes us forward. But there are opportunities that we have not mentioned here that also are in WHO. There's one, the Global HRH Strategy 2030 is currently being developed, and the language of this meeting, I think it's not yet there in that global health strategy, and that's an opportunity to put this language forward. 2, the updated strategy on every woman, every child. One of the key interventions you have there is cesarean section, which is really critical to the output of every woman, every child. Again, it's not mentioned there. A third opportunity is the work of the Global Health Workforce Alliance in relation to universal health care and universal access and coverage. Again, I think we have many opportunities, but a short time window to get this message into those opportunities, and it would be good to see how they get there. Second, I'd like to just call a little bit of a caution. The HRH approach of numbers was what we started with as the JLI. We had 2.3, 1 million for Africa, 2 million for Africa, 4 million for Africa, and now we're talking about 7 million health workers needed to achieve UHC. It's not quite clear if the health workforce for surgery is included in that 7 million workers to achieve UHC. And I hear government well. I hear this many years of advocacy on HRH well, is that governments are always concerned not only how they're going to produce, but how they're going to employ, and how much of the salary of the health workforce, of the health system, is already currently devoted to paying the limited health workforce that we have now. And so there needs to be another argument around how do we pay, not just how do we absorb them, but how do we pay them and scale them within the health workforce? This brings me to the vexed issue of mutuality in migration. I think there is an argument for, which I hear here, of mutuality. There's a co-development in migration, which again is an opportunity that we can explore. And I think this is one of the best places I've had that possibility being real.
Very good. Over here.
Thank you very much. Fahim Ahmed, King's College, LSHTM, and Harvard Global Surgery Associate. So, as we've mentioned, that low-income countries are investing in surgeons who are actually migrating to developed countries and essentially subsidizing their wealthier counterparts. And we've also mentioned how low- and middle-income countries have the duty to strengthen their own systems. But my question to the panel is, isn't it time for more developed countries to actually take the onus and responsibility to support diaspora-led organizations to actually contribute and return back to their countries of origin? Thank you.
Thank you. Unfortunately, we have to close the discussion here. I'm sorry. Thank you so much for a very rich discussion. Very good. Thank you, panelists. I'm now going to introduce the next speaker, and by doing so, I'd like to tell you a dinner I went to last night here in London. I had this wonderful conversation with a lady, a remarkable lady who was in the Royal Society of Literature, and I thought, wow, well, of course, it's London, so it makes sense. And so she was explaining to me, it had nothing to do about global surgery. She didn't know I was a global surgeon, etc. But she had this very interesting question, and she introduced me to this man. Do you know Atul Gawande by any chance? You know, I really would like to ask him this question that I'm writing on, etc. So it's a pleasure to introduce you, Atul. You're not only an attending surgeon and a professor of public health and surgery, but you're and a co-author of the report. You're also a great interpreter of health systems for a wider audience, a great advocate for the patients and providers alike, and really an expert in translating evidence into policy. So, ladies and gentlemen, Atul Gawande.